But just so I'm gonna restart that. So we're gonna get started with the importance of sleep. Um, I'm pretty sure we all understand what sleep is. We know what it is. We've been doing it since we were born. But just because we've been doing it for so long doesn't necessarily mean we've been doing it right. As someone has always told me, common does not mean or common doesn't mean correct, right? So I'm going to talk a little bit about what good sleep is. So just like pain and how people have different perceptions of pain, and something that can hurt you might not necessarily hurt someone else, sleep sort of runs under that same vague kind of definition, right? So we can try to define what good sleep is, but it really is just based on a couple of different terms that we'll use, and then try to make the best of that, basically. So because everyone awakens spontaneously after different quantities and qualities of sleep, and feel alert at different durations, basically, sleep has no, good definition, true definition. So we're going to talk about quantity and quality, which is really the things that we use to quantify what good sleep is. Quantity has been stated to be 7 hours or more a night by the American Academy of Sleep Medicine. So basically, if you fall asleep at 10 o'clock, 7 hours from that, that's when you should be more likely to have a good night's rest in terms of the amount of hours you have. But it's not just quantity, it's also quality. So quality is how many times you wake up during the night while you sleep. And so that can be from significant others or other people or your surroundings, but it can also be from sleep disorders. So if you suffer with sleep apnea or period leg movements, which is also called restless leg syndrome, those disorders can cause you to wake up more times than the average person a night. And so basically what that means is the more times you're waking up during the night, the less sleep that you actually have, the less time you spend in all the sleep stages, so that you don't feel as rested when you wake up, even if you were to sleep for that 7 hours a night that was dictated that we talked about before. So it's not just quantity, it's not just quality, but it's the two of them together. The purpose of sleep basically is to continue to maintain good physical and mental health and just your overall quality of life. So as long as we are understanding that that's what sleep is for, usually when you understand what something is for, you're more likely to find space for it basically in your life. And then the next slide. So sleep insufficiency. So now that we sort of know how to quantify what sleep is or define what sleep is, we should talk about what happens when we don't achieve good sleep. So I just wanted to make mention that because today we are focusing mainly on bipolar disorder, that can cause changes in your sleep. So mania, which will be talked about later, during that you can have periods where you don't think you need sleep, or your body doesn't perceive that it needs sleep. So that means in a 24-hour period, you can be sleeping 1 to 3 hours a night, and you feel rested and fine, but truly that's not enough for your body to do everything that it actually needs to do to rest and recuperate. And then on the other side of that, depression, this can cause you to sleep more on the other side of that. So, and even though we had said 7 hours quantity wise was what we were looking for, having more hours of sleep doesn't actually increase the quality of your sleep. It actually begins to decrease it. So it is a game with the numbers a little bit, and that's different for every person. But some people think, oh, I'll just sleep more and I'll feel better, but you don't feel better. So I just wanted to mention that sleep is so important in bipolar disorder as well. So moving on from that, but let's talk about some acute and chronic things that happen when we don't achieve good sleep. So acutely, this is basically what you see within 1 to 2 days of having a sleep disturbance. You're going to have some brain fog. You're going to feel forgetful. You're going to take longer to respond to stimulus. So if someone is calling your name from the room across, it might take you a little bit of time before you realize that someone is calling your name and to pay attention to them. You can also have a decreased mood. So that includes irritability, low energy, decreased libido, and it can even go up to depression and anxiety. So how rested you feel during the night definitely does play a factor in how you feel the next day and the day after that. usually it takes 2 to 3 days for you to truly feel the effects of a bad night's sleep. So let's say you don't sleep on Monday night, you might not start to feel bad until Wednesday or Thursday. So that's another important factor. So if you think that, oh, I slept for 4 hours and everything was fine, and you do that for 3 days, let's say on that 4th day, you're going to start to feel bad, and it's only going to get worse because it's an accumulative kind of effect. Also, you can have increased sleepiness and micro sleep. So basically, I'm sure we all have those little head nods where we fall asleep for just a brief moment and we don't even know we're falling asleep until our head goes down. It's very common in the first acute phase of not having enough sleep. And it's actually very common when you're driving as well, which I'm sure we understand that can be very dangerous, not only to ourselves, but everyone else on the road. So for these reasons, acutely, we don't want to, for a short period of time, we don't want to be missing out on good night's rest. But let's say that we don't get any of these and we're amazing and our bodies are just super fighters and we just keep sleeping without getting good amount of sleep. What happens later on? So chronically, and I just wanted to mention that it's not insomnia, just based on different definitions of what insomnia is to chronic lack of good sleep. You can have a decreased quality of life. So basically that decreased mood, that cognitive impairment, that sleepiness, all that stuff from that first one will compound on each other in order to make it worse. So you're not going to feel as good as you did maybe a month ago because you're just run ragged, so to say. And then there's also a lot of health implications like cardiovascular morbidity, immunosuppression, which basically means that your body doesn't have the antibodies, it doesn't have the immune support that it needs to fight off all infections and everything that you're going to face in your day-to-day life. Cortisol will increase, and cortisol is our fight or flight hormone. And at a short, to some degree, it is good, but after a while, it can cause other health risks like obesity and diabetes and other things like that. So increasing that in the long run can make you see some diseases later on in life that you didn't have growing up per se. Also, much later on in life, we've seen dementia and Alzheimer's with people who don't have good enough sleep chronically, as well as, unfortunately, increased mortality. So it is very important for every portion of your life, whether that's tomorrow or 5 years or 10 years down the line, for you to get good sleep. And then our last slide, we're going to talk about ways to improve good sleep. So we know that sleep is important, and we know how to quantify it or qualify it. So how do we actually get it? So basically, you should have a good sleep routine and hygiene. Routine is the things you do in order to sleep well. Hygiene is sort of the why behind why you do it. So let's say you want to read before you go to sleep, you would do it as a book instead of on an iPad, right? Because the iPad will give you blue lights and things like that. So the fact that you're switching to a book is the hygiene, but your routine is that you want to read a book before bed. So it's managing your sleep behavior in your environment that is really going to help you to have better sleep at night. The more routines that you go through, or the longer that you do a routine, the more your body will associate that routine with sleep. And so even if the first couple of days you're doing a routine, you're not necessarily sleepy, about 2 weeks later, you'll definitely, like, let's say brushing your teeth before bed is it. The moment you look at that toothbrush, you're going to start yawning. And then also you want to reduce your cortisol, like we talked about before. The best way to do that is through exercise, especially in the early morning or early afternoons. And that helps to decrease it during the day so that it's not a lot built up later on at night, as well as meditation, mindfulness, prayer, managing stress, both in the actual environment, so work, personal, or relationships or whatever it is, as well as outside of the environment. So making sure that you are spending time and you are selecting time where you will focus on yourself so that you can handle your day-to-day life as it is, as well as, let's say, a massage. That's another way to reduce cortisol. The last thing I want to talk about is just some pharmaceuticals, and that doesn't necessarily mean that has to be things prescribed by your doctor. You can get sleepy time teas. Most common ones are chamomile and lavender, just things to make you feel more relaxed before you go to sleep. Melatonin is a hormone our body produces naturally, but again, our bodies are very different. So sometimes you might not have enough So taking that over the counter is a supplement that you can use. And that again is different for every person. Some people take it 30 minutes before bed, an hour. Some people take it in the afternoon just so that they know later on at night they'll be able to fall asleep better. CBD is another herbal substance that you can use, as well as medications finally. And so those are basically some of the key things. There's definitely much more that you can do to help improve your sleep, like bed sheets and the smells and other things like that. But those are some of the key things I wanted to hint and focus on today. And so now what's really what I wanted to speak about in terms of sleep. So I wanted to just turn it over to the audience if they had any questions about sleep or just anything in general that I spoke about, that they can put it in the chat, or they can unmute themselves and ask the question. And we'll take a few minutes for that. Right.
And I usually
Okay,
like to.
since there's no questions for Sarian right now, I'm going to throw out some questions to the audience. The first question being, do any of you all have a bedtime routine that you'd be open to sharing by unmuting yourself or dropping it in the chat? I'll give like 30 seconds for people to throw some responses out. I'm just going to read a few of the things I see dropping out in the chat. So one of the first ones I see that some people like to exercise in the afternoon to help them fall asleep at night, which is something I also like to do as well. Some people don't have a routine yet, but they're trying to get some ideas to get a routine. So please keep dropping things in the chat so we can inspire some people. Some other people take a sleepy time mocktail. Very interesting. So some tart cherry juice, seltzer, lemon juice, and some magnesium powder. Haven't heard of that one, but that sounds pretty cool. Someone started keeping their phone in the bathroom instead of next to their bed. Definitely super helpful. Some bay time, book fun time, shower time, then bed. I think I see a question. Okay, there's one question here. So of what relevance is a daytime nap with respect to the number of hours of sleep per day? I'll throw that out to someone to answer.
So I'll try to answer that the best I can to my understanding. So you said, of what relevance is a daytime nap to, what was the rest of the question?
With respect to number of hours of sleep per day.
Okay. So from what I read and I understand, it's not necessarily napping compared to the hours in the day, but it's napping at to think about it separately, right? So if you sleep, it depends on how much time you spend sleeping. So that sleep cycle that I spoke about earlier, it takes about 90 minutes to go through the whole thing. So if you do a 90-minute nap per se, you can definitely go through that full cycle, and that can be a bit refreshing. But usually that is frowned upon just because everyone goes through that cycle so differently that you don't want to wake up in the middle of the cycle. People who wake up in the middle of the REM cycle or the N3, which was the deep cycle, deep sleep portion, end up feeling groggier and feeling like they don't have enough sleep. So in order to make sure that you don't end up waking throughout those times, they say to take a nap that's usually about less than 30 minutes. 10 to 25 minutes is usually pretty great in terms of time, because that would put you in the light sleep range. of the sleep cycle, so you're not feeling groggy when you wake up, and it does give your body enough time to rest and relax and just sort of reset very quickly to keep you out throughout the day, like a power nap or a cat nap, like they would call it. So it's not necessarily how many naps or how long you should nap in respect to all the things you have going on in the day, but it's based on the sleep cycle, because that is what really tells you if you're going to wake up groggy or not. But because we unfortunately don't have an Apple Watch that tells us what cycle we're in to keep us asleep or anything like that, we just sort of have to guesstimate it. And that's like why 15 to 30 minutes is why they say that's a good time portion for a nap. And usually one nap a day, two if you're really tired, but one nap should suffice. I hope that answered the question.
Thank you for answering. That was super helpful. I'm a big napper myself, so I'll take some of that information to heart. And thank you to everyone in the audience who submitted their answers to the question. And now we're going to transition to the next part of our evening.
All right, so I am really looking forward to just sharing some of the nitty-gritty basics of what bipolar disorder is, because it's something that, unfortunately, bipolar is a term that gets thrown around with oftentimes not the greatest connotation. Like if you know someone is having changes in their mood, someone will say like, oh, you're so bipolar, in ways that really don't speak to what it truly means to have bipolar disorder. So the slides that I have, honestly, I'm probably going to not use most of the slides because I want to make sure that we spend as much time as possible hearing from the panelists. So what I will do is focus in on what I think anyway are the most important slides. So Jada, I'll ask that you just kind of go forward 2 slides. So I just want to share this because I am a physician. I have to make sure I do the legalese disclaimer that this is not to diagnose or to treat, and participation in this presentation doesn't establish a doctor-patient relationship. I am an educator at heart and I love to teach. So that is what we're doing here, a really mini teaching session about what bipolar disorder is. So you can go ahead, keep going, keep going. Right here. So we'll really talk about what it looks like for someone to have bipolar disorder. And also, hold on, give me a second, because I want to make sure the right, give me one hot second. There we go. So I wanted to just kind of talk about the process of diagnosing bipolar disorder. And as psychiatrists, we use this really fat book. I wish I had it next to me to show you, but this fat book called The Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, more commonly known as the DSM-5. There have been multiple versions of this. In fact, actually more than 5 versions, because in between each of the versions, there's like a miniature edit. So that's just kind of the background on how this comes to be. But experts come together and say what symptoms kind of are most commonly seen that represent a disorder. So when it comes to bipolar disorder and bipolar 1 in particular, because there are 2 versions of bipolar disorder, one of the main things is that people will meet criteria for having 1 manic episode in their entire life. So what I want you all to do is, if you can just drop in the chat the letter 1 if you have ever heard the word mania. So just drop a 1 in the chat if you've heard the word mania before. You can drop a 0 if you've never heard mania before. Okay, so I'm seeing a lot of 1s, a lot of 1s. Okay, so what I want to do is make sure that we're all on the same page about what mania means. So here, again, we're thinking about bipolar disorder. The main thing is that I want you to take away from this is that bipolar 1, people will have at least 1 manic episode. Jada, next slide, please. And I see that there are folks joining with us. I got some messages behind the scenes that there were 2 different times sent out, so we sincerely apologize for that. But we are recording, so whatever you have missed is going to be recorded and presented. But welcome to everyone who has joined us so far. So mania. So when we're talking about mania, it looks like just about everyone, at least who kind of dropped a number, has heard of mania. And what we use in our clinical training is this mnemonic, which is a abbreviation of how you can remember certain things. So dig fast is the mnemonic. And someone who has mania will have a period of abnormally and persistently elevated, expansive, or labile mood, meaning that they feel really, really good. And then with that, increased energy or goal-directed activity. And I'm just kind of going over the clinical part. Our panelists will talk more about their lived experience so that you kind of get more flavor as to what that might look like and how that might manifest in someone's life. So with that, someone who has mania is going to experience three or more of the items listed below here that make up this dig fast mnemonic, which include distractibility, not being able to focus, increased goal-directed activity, like I mentioned before, grandiosity, which is the clinical word for inflated self-esteem, flight of ideas, which is where someone has kind of like racing thoughts are popping around from one topic to the next. They're doing more activities that have the potential for negative consequences. Their sleep is decreased, sometimes needing almost no sleep at all for several days. And then there's increased level of talkativeness. And what's really important in mania is that these symptoms last for at least 1 week or lead to hospitalization. Next slide. So then, as I mentioned, if there's a bipolar 1, then that means there has to be a bipolar 2. So similarly, I want you to just put a Y, the letter Y, in the chat for yes, if you have heard of bipolar 2 before. And you can put an N for no if you have not heard of bipolar 2 before. So I want to kind of see yes or no if you've heard of it. Okay, so with this one, there's a little bit more of a mix where some people have heard of bipolar 2, but there are some people who haven't, and this is a safe space. So I'm glad that people are sharing that they don't know, and you're here to learn. So thank you for joining. And I saw a couple of Atasha Jordans. I am the real Atasha Jordan. So if you are not the real Atasha Jordan, please feel free to change your name. There was a glitch in the system of people registering and then the name showing up as my name. But other than that, so with bipolar 2 disorder, it's similar to bipolar 1, but typically the symptoms are not as severe. So there's something called hypomania, where hypo means smaller, lesser than. There's a small version of mania that happens. And on top of that hypomanic episode, there's also an experience of major depressive episode at some point. So whereas in bipolar 1, all you need is just a manic episode, with bipolar 2, you need a hypomania at some point and major depressive episode at some point. Next slide, please. So what you'll see here is that the criteria that dig fast mnemonic, it's actually the same things. But what's different about hypomania compared to mania is that hypomania doesn't last as long. Meaning, so here for hypomania, it's the symptoms are for 4 days compared to a week with mania. And then with bipolar 2, then someone may also have depression in addition to the hypomanic symptoms that they have. So that is kind of like the nitty gritty. We'll go one more slide, Jada. So this slide, we're talking about depression because I wanted to make sure we talk about this too, because bipolar 2, as I mentioned, has hypomania and depressive symptoms. So a major depressive episode, that is, and here's another mnemonic, which is SIGI caps. And again, I'm kind of giving you all a little bit more detail than I usually do, because the questions you sent in advance were asking for these nitty-gritty details. So I'm sharing it with you. And please know that there will be time and space for questions if you have them. But here with a major depressive episode, the person will have for 2 weeks, 5 or more of the following symptoms. So some kind of change in their sleep, whether that's increased sleep or decreased sleep, loss of interest in doing things that they usually like to do. There may be guilt or shame. There may be decreased energy, decreased concentration, appetite changes, and that can be increase of appetite or decrease of appetite. And then psychomotor retardation, which is a fancy word for like physical slowing or agitation, where people feel really restless. Suicidal thoughts are another component of depressive episodes for some people. So again, when you look at this list, a major depressive episode is when someone has 5 or more of these symptoms that are listed out for 2 weeks or more. So that is kind of the wrap up. Jada, if you go forward, treatment wise. So I'll pause here real quick because one of the sayings of CMHI, of Christian Mental Health Initiative, is faith, meds, and therapy. We believe that faith, medication, and therapy, it's a really great trifecta to be able to help us understand ways to treat and deal with mental health challenges. So in the context of bipolar disorder, which our panelists will speak about in just a moment, we really want to think about how can our faith be an important part of the mental health treatment process, of leaning into community for support, discussing challenges with trusted religious leaders, spending time in prayer, like Sarianne had mentioned before, in terms of sleep routines, worshiping, reading the Bible, getting involved in ministry. These are just some examples of how faith can be an important part of the healing process. Next slide. So here I wanted to talk about medication because medication is a really important part of treatment for bipolar disorder. So the 2 sections I want you to really focus in on, the row that says antipsychotic medications and the row that says mood stabilizers. So mood stabilizers, just so that you can like hear of some of the terms: lithium, lamictal, also known as lamotrigine, Depakote, oxcarbazepine. Those are the ones that are most readily coming to my mind, are the mood stabilizers that we use in the treatment of bipolar disorder. Antipsychotics are medications that typically are used in the treatment of psychotic illnesses like schizophrenia. That's why they were initially created, but have been found to be incredibly effective in the treatment of bipolar disorder as well. So antipsychotic medications are also used in the treatment of bipolar disorder, and that's bipolar 1 or bipolar 2. Next slide. Therapy. So, faith, meds, and therapy. We're not going to leave out the therapy part. This slide really is just to show you that there are a bunch of different types of therapy. These 3 don't even begin to list the types of therapy that exist, but therapy can be a really important part of the healing process. And in fact, right now, one of my patients, I love when I get to do therapy and medication management together, because to me, I just love being able to do both. And she's a patient who has bipolar disorder, and I get to work with her both for medication management and for therapy. And it's been a blessing to see her growth and her progression over the time that we have been working together. Next slide. I'm going to skip this for now, but basically I will give just a short answer or a short comment. I usually talk about the fact that spiritual health and mental health are distinct entities, and our panelists will talk about this too. Spiritual health and mental health, not the same thing, but they are very much interconnected. And our panelists will touch on that in a moment. Next slide. So here, yeah, strategies to promote mental wellness. Honestly, I'll just leave it at sleep. Someone asked if the slides will be shared. I can definitely make the slides available to you all, but we're going to focus on sleep for today. These other things like exercise, a healthy diet, positive social supports, leaning into religious practice, avoiding drugs and alcohol, especially actually in the context of bipolar disorder, and then seeking professional help. These are the sorts of things that can promote wellness, because we want to make sure we're balancing the conversation, not only to talk about mental illness, but to talk about mental wellness promotion as well. So these are some of the things that you can consider. And I saw that we do have a few questions in the chat. Let's see. I'll answer. So Mary Lett, love that name, by the way. Is it possible to get access? Oh yeah, you can get the slides. And you would love to share with your husband. I'm glad. Yeah, thank you so much. Yes, and it's being recorded. We're going to post this portion onto our YouTube channel, so it'll be available for replay. We're not going to post the panel because we wanted to make sure that we were respecting the stories of our panelists and not sharing their stories on our platforms, but allowing them to share their own stories as they have volunteered to do today. There was another question: in my clinical experience, how often do I see bipolar 2 being misdiagnosed as generalized anxiety or major depressive disorder? Oh, that's such an interesting question. I can't put a specific number on it, but truthfully, I always just kind of go into patient encounters, especially when I'm meeting a new patient, trying to I keep in mind what diagnoses they have been given in the past, but trying to kind of see them in a fresh lens to see what I think makes the most sense for their diagnosis. And I think that most clinicians, and whether that be a psychiatrist, a nurse practitioner, a physician assistant, would aim to continually be in a reassessment process. So if someone's coming into me and initially it seems like they have bipolar 2 disorder, but over time I learn more and then I realize, oh, maybe they actually have generalized anxiety, or maybe they have major depressive disorder, which, by the way, major depressive episodes happen in the context of bipolar 2, like we talked about. But an astute clinician will always be keeping in mind the fact that their diagnosis could be wrong when new information is brought into play. And I will pause there. Hypersexuality and how to manage it. Okay, I'll answer this one and then turn it over to the panels, because honestly, I just really want to make sure we all hear as much as we can from our panelists. So can you address the issue of hypersexuality and how to manage it? So just to give context for everyone, one of the symptoms in that dig fast mnemonic is increased behaviors that are not typical for the person and particularly can put them at risk. So the ways that hypersexuality tend to come up, and there are many other ways, but the way I have tended to see it the most is that people who typically may not have a high level of sexuality, and meaning a high libido, may all of a sudden be craving sex and seeking out sex much more frequently than they typically would. And then on top of that, they may be having sex with partners who they may not otherwise have had sex with if they were not in a manic episode. They may have sex unprotected, for instance, without condoms or without birth control, and especially if that's a behavior that would be different than their norm. Those are some of the examples of how to manage it, examples of what it is. And then in terms of how to manage it, there are different strategies, truthfully speaking, where these strategies can range from talking about behavioral management during therapy, of what are the things that you can put in place to kind of help prevent some of these behaviors. And then from the more medication management side is where I tend to see it, is thinking about making sure that the medication people are on is at the right level so that the hypomanic or manic symptom, which hypersexuality would be one of those symptoms, would be decreased by an increase in medication or change in medication. So those are the two things, kind of walking through with the therapist, what are the behavioral changes that can take place, and then decreasing symptoms through medication adjustments. So with that being said, I am going to turn it over to the CMHI team, who will be introducing our panelists and allowing our panelists to share their experiences as Christians living with bipolar disorder.
All right. Hello, everyone. I hope you're enjoying yourself so far.